All right, good morning and good afternoon, depending on where you are. Welcome to today's webinar, Common Upper Extremity Problems and What to Do with Them. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts, in collaboration with Dr. Charles Cassidy of Tufts University School of Medicine. We're excited that you've joined us for this presentation and the fourth and final session of the 2021 Injury Insight series. My name is �𝐵𝐲𝐵𝐲𝐵𝐻, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Again, we're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'll pass it to our host, Cynthia Bourbeau, who is president and founder of Medical and Life Care Consulting Services and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified case manager, and certified nurse life care planner for over 3 decades. Cindy, over to you.
Hi, everyone. Thanks for joining today. Can everybody hear me?
Yes, you're good.
Welcome. Great. So welcome to Injury Insight. Before I hand this over to Dr. Cassidy, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series. Is designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery of injuries, illnesses, and diagnoses, both common and uncommon, within workers' comp. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready. And also, with COVID, we couldn't get together. And so we really needed a way to be able to interact with the physicians that we value. And so this was a great program to be able to do that. For this session, we're pleased to have physician specialist, Dr. Charles Cassidy of Tufts University School of Medicine. Can you change the slides? Great. Dr. Charles Cassidy joins us from Tufts University School of Medicine and is currently serving as the chairman of the Department of Orthopedics, while also serving as the chief of Hand and Upper Extremity Service and residency director of the Tufts Affiliated Hospitals Orthopedic Residency. He's also a member of the Board of Trustees of the Physicians of Tufts Medical Center. Dr. Cassidy earned a Bachelor of Arts in Biochemistry from Harvard College and an MD from Northwestern University Medical School in 1987. He and his wife have 2 children, a daughter living and working in New York as an actor, and a son attending Bucknell University in Western Pennsylvania. Welcome, Dr. Cassidy. Thanks for doing this with us today.
Good afternoon. Thank you, Cynthia and Gigi, and welcome. I am broadcasting live from the heart of the Theater District in downtown Boston. And this afternoon, we're going to talk a little bit about upper extremity problems, and some of them are real dilemmas. And here is our outline. First, the hand-brain connection is strong. I'll talk a little bit more about that. Followed by the most concrete one, I think, distal biceps rupture. And then a vexing problem, lateral epicondylitis. 2 really common entrapment neuropathies, cubital and carpal tunnel syndrome. And then a couple of problems at the wrist and hand, including ganglia and de Quervain's tenosynovitis. As many of you know, working with this population, hand problems can drive people crazy. And I love this depiction of the homunculus, which is It's a topical representation of the body, proportionate to the amount of brain space is being used by various body parts. So you can see in this depiction how much the hand impacts a person's brain. It's crazy. Literally, hand problems can drive people crazy. And one of the more common problems that we see is what's called catastrophization. And I love this tombstone of Santa Claus and the kid just losing his mind, believing what has happened or will happen will be so awful and unbearable that you won't be able to stand it. And that can happen after injury. Patients are, generally concerned about their future and feel that pain is a sign that things may never get better. And that is a problem that really needs to be addressed early after injury in order to help facilitate recovery. And as you know, those of you who've been in the office with these clients, there are some telltale signs, including this. And this is a great article from Clinical Orthopedics in 2018, looking at just hand posturing as an indicator of catastrophic thinking. For example, the hand in the palm and the patient reluctant to use it, or filling out the demographic sheet with the non-dominant hand, or posturing one finger in flexion relative to the other fingers. And they're not necessarily a sign of malingering, although they can be. They're a sign that homunculus is really working overtime. Next, I just wanted to address the issues about steroid injections. And I'm talking about intra-articular or peritendinous injections. There's a lot of myth associated with this, and I'll discuss a few. So tendon rupture. If injections are placed appropriately, the likelihood of rupture is extremely low. And so the injections, for the most part, are intended to treat the tenosynovium. So tenosynovitis or tenosynovial hyperplasia. There's just more tenosynovium than there should be. In that, for example, in the carpal tunnel, that would cause carpal tunnel syndrome, or in a finger could cause a trigger finger. And we're not really injecting into the tendon itself, we're injecting into the tenosynovium. And so areas where the injection should not be directly into a tendon are areas where there's no tenosynovium. So for example, like directly into a rotator cuff, you would never do that. We put it into the subacromial space. Or you wouldn't put it into the patellar tendon or the Achilles tendon or the quadricep tendon. And those are where most ruptures occur, when the injections are not placed into areas where there's tenosynovium. The second is accelerated arthritis. And there may be some truth to this. So there was a pretty good animal study looking at intra-articular injections in the animal model, and showed that they can accelerate the development of arthritis. And so that's why we have some trepidation about injecting, especially multiple times, into an otherwise healthy joint. So once a joint is really arthritic, it doesn't matter anymore. But there may be some trepidation in terms of multiple injections into a joint in a younger patient. Transient hyperglycemia, and really this is limited to insulin-dependent diabetics. So non-insulin-dependent diabetics don't seem to have the same problem, but insulin-dependent diabetics can see a significant elevation in their glucose for up to 5 days, and it may be highest on day one, and it can go up. I had one patient whose glucose went up to 600 for a baseline of about 150. So we need to advise our patients who are insulin-dependent diabetic to monitor their glucose and adjust accordingly. Fat atrophy and depigmentation are real problems with certain steroid preparations. This is a photograph of a wrist, the hands to the left, and that's the ulnar head sticking up. And you can see that the skin is really thin, and it's very irritated. You could see depigmentation with some surrounding hyperemia. And patients absolutely hate that if it happens to them. Here's one at the elbow where you can see depigmentation following an injection for tennis elbow. Triamcinolone is the most commonly implicated. It's less common with less potent, unfortunately, but shorter acting steroid preparations like betamethasone. That's this. It doesn't seem to happen with water-soluble steroid injections. So in the people with darker colored skin, It's really important to be careful placing these injections and ideally using a water-soluble steroid. And one tip that's very helpful is to pre-inject with just xylocaine into the space before injecting the steroid. So to confirm that the needle is in the correct place before injecting the steroid will minimize extravasation into the soft tissues. So distal bicep rupture, it's fairly common in male laborers, middle-aged men, 40s to 50s. Not so common in women. If it happens, they tend to get more tendinitis than rupture. Anabolic steroids, of course, are implicated in smoking, and the mechanism is eccentric force. So that's where the elbow is being forced out straight while the biceps is firing. And that would occur, for example, from attempting to catch a heavy object that's falling or tipping, or attempting to lift a heavy object. And in real life, I will show you. You can find anything on YouTube, and so hopefully I can make this happen. And this is a weightlifter. If you look at his bicep, left bicep, and I absolutely love that scream. That is awesome. Tough guy, hung in there through that lift. Oh, I need to exit. Oh, hang on for 1 second. I think I need to exit to get rid of that video because it's still playing. I can do it. Although I hate to get rid of it because I love it so much. All right, here it goes. Pause, escape, stop share. Hopefully that will work. And we're coming back in. All right, so the distal bicep extends from the shoulder. The bicep muscle extends from the shoulder to the elbow, and it starts as two tendons at the shoulder. So one is intra-articular, as you heard from Dr. 𝐈𝐧𝐼𝐮𝐫𝐲 previously, and one originates from the coracoid, and they combine to form a single tendon that inserts into the biceps tuberosity, as you see in the upper image. And while that's happening, it rotates, as you see here. So the tendon actually spins, and as a result of its insertion, it provides a flexion force to the elbow and also a supination force. So it's twisting the forearm into supination and flexing the elbow. So patients who've had this injury may recall a pop, like that guy that we just saw. They may or may not have bruising in the antecubital fossa. They have what's called a reverse Popeye deformity. So if they rupture at the shoulder level, the muscle migrates distally, but if they rupture at the elbow level, it migrates proximally. You're not going to see that in a partial tear. And they may not necessarily have much pain after the incident, but if you evaluate them for strength, they'll have weakness with supination and flexion. And again, they may be more painful if it's a partial rupture than a complete rupture. There's a physical exam test that is called the hook test, as you see illustrated on the right, where the examiner tries to place the finger underneath the bicep tendon. And if you can, then that means the tendon's intact, or at least it's partially intact. If you can't feel it, the tendon's ruptured. So sometimes it's obvious, and sometimes it's not. MRI is usually not necessary, like that guy, the weightlifter who we saw rupture his bicep. You don't need an MRI for that, because it virtually always ruptures at the insertion. Indications include a suspected partial rupture. So a patient who has the right mechanism and they have pain with resisted supination, pain with resisted elbow flexion, or an unusual mechanism. So for example, I had a guy who was a rock climber who had a rope wrapped around his upper arm, and he slipped, and he actually ruptured through the muscle, which is extremely rare. But it just felt different. The mechanism was different, and it was very helpful information preoperatively. Or a late presentation where you're debating, should I fix it? Do I need an allograft to get back down there? So the illustration to the left, you can see the abnormal fibers with the surrounding edema, and the right looks like a good bicep tendon where the arrows are. So what happens if we don't treat these operatively? So if we leave them alone at the shoulder, patients may have some cosmetic deformity, but it doesn't seem to affect strength. But because the two tendons converge into the one muscle and insert into the one tendon distally, if it ruptures distally, they do lose supination strength, up to 40% of supination strength. That would affect, for example, turning a screwdriver, and they lose supination endurance. They also lose about 30% of elbow flexion strength. The other flexor is the principal flexor. It's called the brachialis, which is deep to the biceps. And that's actually the principal elbow flexor. That's why they don't lose that much elbow flexion strength. Sometimes these patients, if treated non-operatively, will have cramping, where when they're trying to lift, because the muscle's retracted proximally and the tendon is sort of stuck down proximally, they may have a cramping when they lift. And so these days, because the methods of fixation are good, in patients who are healthy enough, we almost always will fix them. So there are a number of ways to fix them. The first is what's called a cortical button, where we drill a larger hole in the near cortex and the smaller hole in the far cortex, and use this little, it looks like a little bracket. And my analogy is, it's sort of like if you go to a clothing store and you buy a shirt that the price tag is affixed to a piece of plastic. That's a T, and the way it's inserted is it's inserted in a straight line, and then when it gets through, it turns and it can't get back out. And that's the same thing, is same kind of structure as a cortical button. Very, very strong. Suture anchors we use for a lot of things. Definitely one anchor is not strong enough. Two anchors come close, but not quite. And then three is an interference screw. Like sometimes we would use it for ACL reconstruction, which again is not as strong. So it turns out that the cortical button is the strongest. And that's a photograph of an X-ray after that cortical button. It's turned 90 degrees. That's why it looks small, but it's about 11 millimeters in length. Post-operatively, I just put patients in a sling for comfort, have them start moving it right away. Some surgeons immobilize for 2 to 4 weeks with a cast followed by a brace. The cortical button is strong enough that you don't need to do that. But the risk is that patients will feel good early and maybe do too much. So I like to have them move it right away. They typically don't need any therapy, so it's not worth it prescribing therapy early until they're ready to strengthen. And I wouldn't start strengthening until 6 to 8 weeks at the earliest. So the fixation is intended to hold the tendon to the bone, but if it never heals, eventually that will fail. So that's the point of protecting it early. And so when I have them start strengthening, they do concentric contractions. So they do light curls, and then they take their other hand to help to straighten it out. So to avoid eccentric contraction, because that's the mechanism of injury, and then gradually increase. And so again, this typically happens in heavy laborers. And so they're not going to get back to work for probably about 4 months if there's no light duty available. The most common complication is transient numbness in the lateral antebrachial cutaneous nerve distribution, which is a continuation of the musculocutaneous nerve that innervates the biceps. So that nerve is right underneath the bicep tendon, just on the side of it, and it can get irritated, and they'll have potentially have a little numbness like you see in green in the forearm, which I would say, I inform patients that they're going to have that. It happens maybe up to 40% of the time. This is not a disabling problem. I would say it's more of an, they notice it, but that shouldn't keep them from getting back to work. Lateral epicondylitis, very vexing problem. And this would apply to medial epicondylitis, which is about 4 times less common. So basically same condition, opposite side of the elbow. So interestingly, it's not really an itis. It's an osis. So thought to be maybe an overuse injury in a relatively hypovascular area where repetitive microtrauma leads to like little tiny tears. And for whatever reason, the body doesn't manifest the normal healing response to injury. And so the tendon just kind of sits there. And almost universally, this involves the extensor carpi radialis brevis, which originates from a very small facet from bone at the lateral epicondyle. And so why does this happen? So the ECRB, it stabilizes the wrist for grip. So if you didn't have a strong wrist extensor and you grip something vigorously, what would happen is your hand would collapse, your wrist would collapse into flexion. So for your fingers to function, you need to have a strong grip, strong wrist. And so that muscle is working overtime to allow your fingers to work better. And because it originates from a pretty small spot, that I think predisposes it to have this problem. If you look at this tissue histologically, it's called angiofibroblastic hyperplasia. It is not an itis. There are a few inflammatory cells. So it looks bland, which is interesting. So why does it hurt so much? It's fairly common, most in early middle-aged, equal predominance of males and females. Most patients who get it don't play tennis, 95%. Maybe related to repetitive activity, like I said. There is a dose-response relation between lateral epicondylitis and work involving loads of greater than 20 kilograms in repetitive movements of the arm. So repetitive motion does seem to be a contributing factor. I would say there may be patients who are just predisposed to get it, right? And this is called mesenchymal syndrome. For whatever reason, some patients are predisposed to get tendinosis at multiple sites, and those patients may have increased BMI, these some other tendinopathies. So like rotator cuff disease, very common in patients with lateral epicondylitis, carpal tunnel, the Quervains, veins, smoking, history of oral steroid use, and low social support is an interesting one as well. If no inflammation, why does it hurt? So it looks as though if you do EMGs of these patients, there's increased ECRB muscle activity, like disproportionately increased. And there are free nerve endings found in the granulation tissue in lateral epicondylitis. Substance P has been implicated, which is a pain generator, and increased levels of glutamate in symptomatic patients. So there may be some local factors that are responsible for generating that perception of pain. Is there something intra-articular going on? So you have to think about that. Like, is there osteochondritis to the capitellum, or do they have a plica? But usually the diagnosis is straightforward with the patient history. They may report pain radiating down their forearm, but they're tend to right at their lateral epicondyle, and they classically have pain on resisted wrist extension, which is exacerbated by extending the elbow. So they may not have it with their elbow flexed, but as you extend their elbow, it puts the muscle on stretch and makes it worse. Is it worth getting imaging? Yeah, over 20% of patients have some kind of bony fleck. And the way I think about it is the tendon is failing, and the bone is trying to keep the tendon from rupturing, and it's sort of growing out to hang on to that tendon. What about MRI? So MRI it can be confusing. So here's a coronal image of a patient with epicondylitis. You can see some signal change laterally with a circle around it. But interestingly, there's an inverse correlation between MR findings and pain. So in this particular study, patients who had, quote, mild tendinitis tended to have more pain than patients who had a rupture, which is sort of consistent with what we do surgically, because when we do the surgery, we actually complete the rupture of the tendon. The tendon doesn't spring down the forearm because it has lots of fascial connections, but part of the problem is traction on abnormal fibers. And when we do the surgery, we'll talk about it, but we release the fibers to take the tension off, and patients actually have less pain. So it gets confusing, because if you tell a patient, oh yeah, we got the MRI and it shows mild lateral epicondylitis, they'll say, well, that doesn't make any sense to me because it's really hurting a lot. And so that's where I don't even get into it. I don't even get the MRI. The times to get the MRI, I think, are for revision surgery, or if you suspect there's something else going on, because you already know the diagnosis is pretty straightforward based on the history and the physical exam. So the natural history is not well studied. There's this wait and see approach from the 1930s where it was thought that 75 to 90% will resolve within a year. But the best natural history study that I came across was of patients followed 1 to 5 years who did not have surgery, and only 37% were symptom-free. So it tends to be a nagging problem in lots of patients. So how do we treat it? When there are over 40 described methods of handling a problem, like lateral epicondylitis, either problem's simple or we have no idea what we're doing. And I think it's a little bit of both with this. And I love this quote. Most non-surgical treatments for lateral epicondylitis are focused on suppressing an inflammatory process that does not actually exist in conditions of tendinosis. So there are really contradictory approaches. And this is, I would say, for the average patient is quite confusing. So there's sort of the rest arm and there's the stirred up arm. So rest makes a lot of sense. You know, if something hurts, it's intuitive to rest it. And so examples of that, non-steroidal splints, activity modification, therapy, steroid injections, iontophoresis, ultrasound, sclerotherapy, acupuncture. Induce inflammation, so stirred up. It's for whatever reason, the body's not manifesting the normal healing response, and we want to like jumpstart it to heal. So how do you do that? Manipulation, autologous blood injection or PRP stirs it up, or radiofrequency ablation, or prolotherapy, shockwave treatment, or surgery can stir it up. So the literature is a little bit confusing, and I would say literature that's in the therapy, from therapy sources tend to show benefits to therapy, but studies that are in the surgical literature don't seem to show long-term benefit from therapy. So straps, like a tennis elbow strap, I think of it like a capo on a guitar. So it makes the muscle think that it's originating from under the strap, takes some of the pressure off the origin. It's been shown in cadaveric studies to decrease the stress about 15% at the elbow. Non-steroidals, plus minus, you know, some patients do benefit from them. Iontophoresis and ultrasound, they tend to have immediate relief, but it doesn't last. So patients feel better that when they leave the office, but by, you know, a couple of days later, they're back to baseline. And the same thing with physical therapy. So now eccentric loading is different. So eccentric loading is you're really, you know, lifting, doing curls to try and aggravate it to get it to heal. And there's some evidence that that can help, but most patients won't tolerate it. It just hurts too much to do it. So there are some studies, comparative studies. So here we're comparing PT with ultrasound, deep friction massage, and exercise, a steroid injection, or just wait and see, tell the patients it's going to get better eventually, and non-steroidal. So how about early on? The success rate, 92% with injection. And I can tell you based on my practice, steroids work early. Now, they take away the pain, but they don't necessarily get it to heal. All right, at 52 weeks, this is interesting. So there was some deterioration in the effectiveness of the injection, whereas therapy or wait and see seem to have better results at a year, but we feel compelled, obviously, to intervene early. And now there's a limited amount of data on steroid injections and the long-term consequences for tendinitis. So you know how I said earlier, we like to inject into tenosynovium. There's really no tenosynovium there at the tendon origin. So yeah, could it cause it to rupture? Absolutely. Is that a bad thing? Not necessarily, because when we do the surgery, we actually rupture the tendon. But there is limited data suggesting that patients do worse at a year if they've had a steroid injection. Maybe it is in part that patients feel so good, they get back too quickly and aggravate it. I think we need more evidence before we could conclusively make a statement about it. But here's another one. So PRP versus corticosteroids for chronic lateral epicondylitis. If you see early, this steroid in the circles, patients feel better from a steroid injection. They feel worse after PRP. There's no question that it gets aggravated after PRP or autologous blood. But there's an inflection point at about 3 months or so where the PRP patients tend to be continuing to improve, whereas the steroid injection may wear off. How about PRP versus steroid or saline? Saline was like a placebo, although you do stick a needle in there. So it's not totally a placebo because you can generate a healing response from just sticking the needle in. At 1 month, the steroid group was better, like I had said earlier. They feel better faster. At 3 months, all groups had a reduction in pain. So it's not really compelling evidence to pay for PRP necessarily. There is some evidence to support it, but it's not a panacea for this. There are other injectables, and I would say that they're totally regional and personal preference practice-based. Sclerotherapy to decrease vascularity, which makes absolutely no sense to me. If the problem is a hypovascular area, why would you want to sclerose a vessel that's helping to get it to heal? But it seems to work just as well as anything else. So that's one of the 40. Prolotherapy, induce inflammation to get it to heal. Botox has been studied. So Botox the muscle, just to give it a break to try and get it, things to heal. Patients complain of finger weakness from it, and it doesn't necessarily work. So how about shockwave treatment? No objective benefit, don't do it. How about surgery? Well, the conventional thought is the indications for surgery include severe pain, unmitigated by at least 6 months of conservative therapy. So that's a long time for a laborer to be out of work. This is one of the most frustrating problems, I think. Fractures are much easier. It's very binary, the decision making. It's broken, fix it, it heals, they get back. This is kind of can drag on and on. So how long can patients and physicians tolerate the wait and see approach? So in general, we say 6 months, but maybe some exceptions. What are the options? Limited debridement is the most popular. So this is a right elbow. So the hand would be to your right. And this is the incision at the lateral epicondyle. And so we approach it and we excise the abnormal tendon. So anything that's looks funny, we just take it out. And like I said, the muscle doesn't spring back down the forearm. They don't have any weakness as a result of that. Other options, open release, percutaneous release, arthroscopic debridement. So here's percutaneous, and that can be done in the office under local anesthesia. So this is sort of like the ultimate in terms of conceptualizing the release helps. So just local anesthesia, numb it up, use some topographical references or an ultrasound, and then just cut that little tendon. They seem to have, a shorter post-operative recovery, but it is totally blind. So it does carry the risk of damage to other structures like the ligament. And I don't do it often. The next is arthroscopic debridement. Arthroscopic debridement is a really elegant way of doing the same thing. It's kind of paradoxical in that it's an extra articular structure that we're treating, but we're going through the joint to get to the structure outside the joint. But it can be done through 2 small incisions. And the recovery seems to be quicker than doing it open. And so I will do this for patients who have tenderness at the tendon itself and not the bone. If the bone's really tender, I think it's probably better to do it open. And then sometimes these problems are associated with radial tunnel syndrome, which is kind of beyond the scope of this talk, but you can release the radial nerve at the same time. I would say if people are thinking about radial tunnel syndrome, it's probably better to do an injection at the tendon origin because it may be referred pain. And you could just use some anesthetic if you don't believe in steroids and see if their forearm pain gets better. If it gets better, they don't have radial tunnel syndrome. They just have some referred pain. How do these patients do? The most objective data show 40 to 90% pain relief at 1 year. So that's quite a spread, and it might be one of the reasons why it doesn't have a great reputation. I would say, in my practice, every patient is glad they've had it done. Not every patient is totally pain-free with every activity. As I mentioned, arthroscopic and percutaneous procedures report the highest success, but are the least commonly done. I don't really like the idea of percutaneous unless you have a true expert. Arthroscopic is pretty straightforward. So how many of these are pain-free? This is the open technique, the best long-term results that we have, 10 to 14 year follow-up, 97% improvement, however, only 49% are symptom-free. So again, patients in general, happy they had it done, not everybody's totally pain-free. So we have a few questions, we have 3, I think. So here's the first one, and this doesn't have a single correct answer. This is actually a patient of mine, real life. A 50-year-old baggage handler at Logan Airport develops acute lateral elbow pain during the course of a busy day. There's no light duty available. You recommend continued regular duty, steroid injection, physical therapy, PRP injection, or early surgical intervention. If you can see the ARS question pop up on your screen, if you could just click on the box that you think is the right, or the circle that you think is the right answer, and we'll tally it up.
All right, everyone, go ahead and select the choice that you think is best, and we'll give it a few more seconds and end the poll. Let's get a few more. We have low participation. Please take a look and see which one you would recommend. All right, we're going to close the poll in 3, 2, 1. And there are the results.
Yeah. All right, I can't disagree with that. I think the patients may disagree with it, but give it a shot. Yeah, it's a very frustrating problem. All right, let's move on to cubital tunnel syndrome. And I do want to leave time for questions. So if I don't finish, I'd rather answer your questions than just go through a couple more. But let's go through 2 types of nerve compression. First is the ulnar nerve. The ulnar nerve originates from the lower trunk of the brachial plexus. So things that are up in the lower trunk area of the plexus can cause symptoms that may overlap with cubital tunnel. So, and the most common, I would say, in my practice is thoracic outlet syndrome. Thoracic outlet may present as cubital tunnel plus some other stuff. There are multiple sites of potential ulnar nerve compression around the elbow, but really the focus is at the medial epicondyle, the cubital tunnel itself. Patients who have cubital tunnel will report numbness in the small finger and ulnar half of the ring finger on both sides. Occasionally, they have an anomalous innervation where it may extend into their middle finger. But this is the classic one, the light blue, not in the forearm, just in the hand. There are muscles in the hand that are innervated by the ulnar nerve. So starting with in the forearm, the FDP of the ring and small finger, and the FCU, flexor carpi ulnaris. And then the intrinsic muscles, the fine muscles in the hand that are responsible for dexterity. So patients who have mild ulnar nerve compression know paresthesias in that distribution brought on by elbow flexion. So elbow flexion increases the pressure in the cubital tunnel and it may elicit their symptoms. So they may have medial elbow pain called neuritis. So like an aching at their elbow, it may radiate down their forearm, but the numbness is in their hand. They may have night symptoms because everybody tends to curl up at night. Late symptoms will weakness of grip and pinch, hand clumsiness, or hand deformity. Like for example, they can't stick their little finger or put their little finger adjacent to their ring finger to get their hand in the pocket. So this was a study done at the Brigham a long time ago, 1990, where they looked at carpal tunnel syndrome, but it applies well to cubital tunnel as well. So if we use the hand pain diagram, which I think is very important to do in the office before you see the patient, cubital tunnel, very specific. Ring, small finger, hand, not forearm. If they just have on one side, that means they may have compression at the wrist level. So if it's on both sides like that, it's at the elbow universally. If it's just in the front, it's likely the wrist, which is not very common. If they report it radiating all the way up the forearm or numbness all the way up, then I would think about thoracic outlet syndrome. Physical exam, you want to evaluate for masses at the elbow, subluxation of the ulnar nerve, Tinel's sign, elbow flexion test. So flexion increases the pressure. Flexion compression test, like what I'm doing there. If you put pressure on the nerve as it's flexed, it's going to bring out the symptoms faster, which is great. And at the hand, the resting posture, and I'll show you some photographs. And then the sensation like we talked about. So how good are these tests that we do? So provocative testing for cubital tunnel, the sensitivity is 70%. Elbow flexion, not great by itself, but flexion compression is really sensitive. But it's important to note that there's a very high false positive rate. So Tinel's sign may be as high as 50%. So patients may just have sensitive nerves that they're very close to the skin. And so obviously you want to compare it to the other side, and it has to be taken in the context of their symptoms and other findings. These are findings of late cubital tunnel syndrome. This is called the papal sign or clawing, where the ring and small fingers are in this posture, extension at the MP, flexion at the PIP. They have what's called a Froment sign. Because of that first dorsal interosseous atrophy, they substitute with their flexor pollicis longus to pinch. You can see hyperflexion there. And then they have loss of this interosseous muscles and flattening of their palm. Wartenberg, inability to adduct the small finger. Patients complain of that. They can't, like their small finger gets stuck when they're trying to put their hand in their pocket. What's the underlying pathology? Compression, direct pressure, elbow position, mass effect, not that common. Traction. So when you bend your elbow like this woman for a long period of time, there is some traction that's occurring at the elbow. Or it could happen from trauma, or you could have a double crush, like I mentioned, thoracic outlet plus cubital tunnel. Should we get nerve studies before operating? I think so. It's the best objective information we have, and it can prognosticate depending on the severity. Double crush, like I mentioned, thoracic outlet, usually be negative with thoracic outlet, but if they had a polyneuropathy like diabetes, that would be picked up. And also, cubital tunnel surgery is a B operation. It's not a home run necessarily. Patients who have advanced cubital tunnel don't necessarily recover fully. So it's nice to have a baseline if their symptoms don't resolve. So you can say, hey, listen, it may not be perfect, but your nerve studies, subsequent nerve studies show that it's better. There's nothing else to do. So we look at conduction velocity across the elbow. So I tell patients miles per hour. So if it's less than 46 miles an hour, and it picks back up, that's likely, it's consistent with cubital tunnel, or if it drops 10 meters per second, like there's a traffic jam, picks back up. So here's an example of a nerve study where you can see below the elbow, conduction velocity 38, at the wrist level 59. So it's slow at the elbow level. A great way of doing this is what's called inching, where you measure over short distances. And you could see, like I said, on the highway, the car traveling 67 miles an hour, drops down to 33 at the elbow, picks back up to 60 in the forearm. And it shows you that there's focal slowing. Whereas if you had, for example, a polyneuropathy, it would be like 30, 30, 30, 30, and never pick back up. How about x-rays? I think if they have limited elbow motion, like you think maybe they have arthritis or deformity, I would get some. You don't necessarily need to get them. Ultrasound, to me, it's like checking the wiring in your house. Like you're looking at the wire, it looks fine, but it doesn't really work. I'd rather have the nerve studies myself. MRI, there was a study that looked at asymptomatic patients. 60% have abnormal signal intensity in the ulnar nerve. So I think maybe we'd be diagnosing too much cubital tunnel if we just looked at MRI. So I like the EMGs for this. The classification that we use most commonly is this stage 1, sensory only, like my hand falls asleep when I keep my elbow bent. Gets better when I straighten it out. Stage 3, intrinsic paralysis, like those photographs I showed you with the loss of intrinsic muscle. Stage 2 is in between. The irony is this, patients do best when it's stage 1. And this is where maybe you're saying, well, it's only every once in a while, maybe you don't need surgery, but that's the time when they actually could have a complete recovery. If you wait until they have paralysis, it's too late. So I would say it's definitely worth, trying some non-operative things first, but think about this when you're thinking about, whether to do surgery. Better not to wait forever, but mild doesn't necessarily progress to severe. If it's moderate, I would recommend surgery. So patient education is a big part of it. Avoid leaning on your elbow, avoid prolonged elbow flexion, hands-free. Use of phones, for example, very important. A night splint like this helps to keep you from bending, so it gives the nerve a break at night. Non-steroidals, anecdotally, I don't think they necessarily work. And if a patient has really advanced cubital tunnel and they're older, they're not going to get better with surgery. So if they're painless, I just leave it alone. So what needs to be released? So this is the cubital tunnel within that circle. That's what needs to be released. Okay, so there's quite a range of surgical options. So on the left, in situ, that's my incision. Right, ulnar nerve transposition. So some of it is surgeon preference, but clearly on the left, the recovery is faster than on the right. The controversy is the strain. So when you release the nerve at the elbow, you take the pressure off it, you unroof it, but you don't necessarily alleviate the strain. So when you bend your elbow, the nerve does get stretched out a little bit, right? So if you do an in situ decompression, it doesn't alter that, but it turns out it doesn't really matter. So in general, the outcome of in situ decompression is as good as transposition. And there are clearly fewer complications with in situ. So the exceptions, so when would we do a transposition? If the nerve's unstable, if it's dislocating, usually you can tell preoperatively, if it's dislocating, it will get worse if you just do a release. So we transpose those nerves. If the patient's really thin and the nerve is extremely sensitive, that might be an indication to do it. If you're doing revision surgery, like if they had a release in the past and you're reoperating, generally speaking, we'll transpose it. If they have arthritis, so if the space in the cubital tunnel itself is not normal, it's better to get the nerve out of there. In throwing athletes, we may transpose the nerve. So how do these patients do? The outcomes are difficult to assess because of inconsistencies in outcome measures. So realistic expectations are critical. These patients may not see much improvement right away. So what I tell patients is if you have fluctuations in numbness, that tends to get better quickly. If you have night pain, that tends to get better very quickly. If you have baseline just feels numb, that's going to take a long time, may not improve completely, but it can improve for up to 2 years. So as I mentioned, the milder the condition, the better the results. And I call it a 75% or B operation. How long does it take these patients to get back to work? You know, if they have in situ, most patients don't even take narcotics after in situ. We do give them a few pills, but they could get back to work quickly. On the other hand, if you did a submuscular transposition, those patients are going to be out for months. So here's question number 2. A 51-year-old woman has left hand numbness for the past 2 years. Examination reveals decreased sensation over the 5th metacarpal region, little finger, both palmar and dorsal, normal strength. Brace treatment has failed to provide relief, and the EMGs reveal ulnar nerve compression with decreased conduction velocity. The next step is ulnar nerve decompression at the wrist only, wrist and elbow without transposition, wrist and elbow with anterior submuscular transposition, elbow only without transposition, elbow only with anterior submuscular transposition.
All right, don't be shy. Please select the best answer, and Dr. Cassidy will let us know how we did. Give it a few more seconds. Get a little bit more participation. Okay, shutting down the poll in 3, 2, 1.
Okay, so if they have palmar and dorsal numbness, that means it's not coming from the wrist. It's coming from the elbow. And I just lost my little thing. So with the answer, but the right answer is at the elbow without transposition. So there's really little evidence that we have to transpose these nerves unless they're unstable. So if they have numbness on both sides of their hand, there you go. Thank you. And we don't need to do their wrist. I think, you know, decompression at the wrist it should be performed extremely rarely. So at the elbow, it's pretty common. It's the most common, and without transposition. And those patients, like I said, they tend to have very little pain afterwards. They could get back quickly. And I tell them, you know, it's not going to be normal for a long time. It doesn't mean you can't work. All right, I think we should just conclude with carpal tunnel. And Gigi and Cynthia, next time I want to have this a 3-hour session instead of a 50-minute one. Let's, because there's so much to talk about the hand. The hand is just awesome. Okay, because let's finish, because this is the most common, I would say, carpal tunnel. This is a cross section at the wrist level. So the carpal tunnel itself is a space that's bound on 3 sides by bone and 1 side by a thick ligament. So it's a fairly rigid space. It's open proximally and distally, but it can't really accommodate swelling. So it's all the flexor tendons to the fingers go in the same space as the median nerve. And you can see in this illustration that the ulnar nerve is above the carpal tunnel. It's not in the carpal tunnel itself. So it's not affected by carpal tunnel syndrome. This is a patient who had advanced carpal tunnel. The hand is to the right. You can see the nerve's all swollen, and you could just envision it's sort of like an hourglass where the nerve is constricted, and there's a backup. It's sort of like a garden hose with a lot of pressure, and your car tire is sitting on the hose, and it's just bulging out like that. And that can happen with long-standing carpal tunnel. So the classic history is nocturnal pain, night pain, numbness and tingling in the fingers, difficulty picking up small objects, and buttoning, which is a late complaint. So in contrast to the ulnar nerve depicted in light blue, the median nerve is in that mustard color. So thumb, index, radial have middle, radial have a ring, and then the tips of the fingers on the backside. So in the differential, the most common is C6. There's where the most overlap is. So if you look at the illustration on the bottom, sensation, thumb, index, 6-shooter, just remember 6-shooter. So if patients have just numbness in their thumb or numbness in their thumb and index, and that's it, it's not carpal tunnel. It's likely C6 radiculopathy. And it does extend up the forearm like you see there. But sometimes I've had a couple patients come with just a numb thumb and it was C6, not carpal tunnel. So with that hand pain diagram, like we talked about earlier, ironically, the most common complaint is my hand falls asleep. Some patients are very astute and they'll say, oh yeah, it's my thumb, index, middle, and radial have a ring finger. They don't usually say that. They might say, oh yeah, my pinky's not as involved, but usually they'll just say my hand falls asleep at night. I got to shake it out. That's carpal tunnel. So early, the signs are nerve irritability, like night pain, activity-related numbness, late, constant, numb, difficulty picking up small objects. The nerve is primarily sensory at the carpal tunnel, except for the thenar muscles. And you can see on the right, the thenar muscles are normally convex. If you look at a profile, and you can see this is concave, it's a sign of atrophy. So that's a late finding. So who gets it? Strongest risk factors: older age, females much greater than men, males, high BMI, pregnancy, diabetes, thyroid disorders, systemic arthritis, high hand wrist repetitive rate. That's in our ARS clinical practice guidelines. So that is a risk factor. Protective exercise, protective for almost anything. Interestingly, anything hand related. Exercise is good. How about Tinel? Tapping on the nerve elicits electric-like shocks into the median nerve distribution. Sensitivity, I would say it's very high early on, and then it deteriorates over time. So as the nerve problem gets worse, it's not as irritable, so the Tinel becomes negative. Doesn't mean the problem's gone. Phelan sign, this is Dr. Phelan demonstrating his own sign. That's flexion of the wrists increases the pressure in the carpal tunnel. Sensitivity, it's okay, not a great one. This is a little bit better. It's called Durkin's or carpal compression test. Direct pressure over the nerve at the wrist elicits those sensations, and it can be exacerbated by wrist flexion. So if you flex it and push on it, it happens faster. What else could it be? We talked about that already. When do you get nerve studies? I would say I would do a pre-op for all work-related claims before I do surgery. If the diagnosis is unclear, if you suspect a double crush, like we talked about diabetes or cervical radiculopathy or pronator syndrome, which is rare, or if you tried an injection and didn't get any better, I would definitely get a nerve study. So how about the practice guidelines? Moderate evidence supporting EMGs and that diagnostic questionnaire, just the hand pain diagram. That's very good. Moderate evidence against MRI and ultrasound. How about treatment? Strong moderate evidence in favor of splinting at night. You don't have to splint all day long, but at night, steroid injection, ketoprofen, that's done by therapists. We don't tend to use it, and surgery works. Magnets don't seem to work, although they seem to be popular. Non-steroidals, vitamin B6. And again, physical activity, exercise, protective. What about typing? This is one that patients where they found an inverse relationship between typing and the development of carpal tunnel, meaning that the better the typist, or I shouldn't say that, the more they typed in terms of the volume of typing, the less likely they were to develop carpal tunnel. And they're probably because they're great typists, they're much more efficient than me. Steroid injections work if it's truly carpal tunnel. So 80 to 90% symptom resolution at a month. However, it's only a temporary solution. So the symptoms recur and 75% by 3 months. And for some reason, young females don't respond as well. But a good response to injection predicts a successful carpal tunnel release. So if the patient said, boy, that helped a lot, it came back, they're going to do well with carpal tunnel surgery. Ergonomic modifications, I would say it's more job specific, and you really need to have coordination in terms of understanding what modifications at work can be made. When do you operate? Refractory night pain, constant symptoms. If they have nerve fiber loss, that means it's more than mild, definitely. Or older patients, and this is not what we're talking about today, but older patients, their nerve may not bounce back. And this is, we'll call this the last one. So the use of a cock-up wrist splint for carpal tunnel syndrome is most useful for improving nerve conduction studies, improving thenar muscle weakness, improving sensation in the median nerve, improving night symptoms, and delaying the need for surgery.
All right, final question. Please select one, and we'll close it down in 3, 2, 1.
Okay, that's awesome. Yes, improving night symptoms. Patients sleep better with the splint. It doesn't necessarily cure them, though. I totally agree with that answer. Excellent. And I just had a couple slides on endoscopic versus open and narcotics. So we'll just talk about narcotics. We didn't really talk about it, but it's important to note that after carpal tunnel, especially endoscopic, most patients don't take narcotics, or if they do, fairly few. And there was a pretty good study demonstrating that they shouldn't receive more than 10 pills. So this is not the patient who's chronically on narcotics, but the average patient just undergoing surgery. They don't require much. There's some evidence that endoscopic will get you back faster, a little bit faster, but the outcome long-term is equivalent whether it's done endoscopically or open. I know people are very passionate about one or the other, but both work. I think we should stop there.
All right. Awesome. Thank you, Dr. Cassidy, for sharing such great information about upper extremity injuries and treatments. At this time, we will shift into our question and answer segment. So please be sure to submit your questions using the Q&A feature within your Zoom dashboard. We already have a few questions lined up. The first one is regarding the use of PRP injections. How many injections would be an appropriate number for treatment before surgery is offered?
Yeah, I would say that it's shared decision making, and not to say that the government knows everything or insurance companies know everything, but it's still not approved by insurance. There's some, I would say, fairly good data of moderate success with PRP injections. So I'm using a lot of adjectives to hedge. And so to me, it depends on the duration of symptoms, the aversion to surgery, but certainly no more than 3. So the studies that have looked at them have looked at up to 3. And the same thing with autologous blood. So autologous blood is like cheap PRP. It's whole blood injected, which doesn't involve a centrifuge. A lot less expensive. And there has not been a head-to-head comparison between the two, but that study, those 2 studies involving autologous also were up to 3. But I definitely wouldn't do more than 3 injections.
Okay, thank you. Here's another question. It seems to come on the heels of your portion about narcotics. And what's your policy or thoughts regarding pain management? I know you shared what the recommendation was, but what are your thoughts and how might they have changed over the last couple of years, and especially for those in post-op care?
Yeah, I think, with the opioid crisis, much more attention has been given to this issue. So I think the tension is this. We want our patients to be happy. We like good Press-Ganey scores. We don't like to be called in the middle of the night, but we want to do the right thing for patients. And I think that's really where the tension is. And sometimes, patients have a lot of anxiety about how much pain they're going to have. And you can tell them, other patients don't seem to have a lot of pain. And, some patients just don't buy it. And so, yeah, so I never give, aside from, for example, a trigger finger, I never give patients 0. I always give them a few, but I tell them what the data is, that the average patient takes takes fewer than the number that we give, which is 8 to 10. And I'm not talking about bony procedures, but the soft tissue procedures. But I think the most important part is having that discussion before the surgery, not negotiating in the holding area right before the operation, but having that conversation at the time the decision is made to have surgery. And then also utilizing anti-inflammatory medications that are synergistic. So I tell patients, alternate. Take as soon as the anesthetic wears off, take a couple of the pain pills, and then 2 hours later, if they can take ibuprofen, I have them take ibuprofen, or if not, Tylenol, and then alternate a couple of times, and then that tends to take care of it. The other thing is I tell patients to move their hand. I think a lot of patients assume that, they have an injury, we operated on them, their hand is hurt and they should rest it. And actually that's a bad thing for most injuries. You want to keep the fingers moving. The fingers are like pumps. They'll pump the fluid away if they're moving. And once they start getting swollen, then it really complicates things. So I think educating those patients, of what they can do instead of what they can't do is very helpful.
Thank you. I think we have time for one more question, so submit it. We have one lined up. This one is regarding fracture treatment. Often we see patients who've been in the emergency room initially, the body parts stabilize, and then they're referred to orthopedics. At Tufts, is there a mechanism in place to kind of fast track these patients so there's no delay for them to be seen post-injury? Just to add some context, it looks like this person is saying that we've heard of other area hospitals where like that follow-up evaluation is delayed due to the process of getting approvals from workers' comp, and this could be detrimental to the patient. What do you guys do?
Yeah, so we don't have any restrictions, specific to workers' comp, and we have fracture follow-up clinics on Wednesdays at Tufts. So in the morning is a hand clinic, and the afternoon is the rest of the body clinic. So hand and elbow in the morning, and everything else in the afternoon. And patients will be scheduled for the next week, Wednesday. That having been said, if the patient has a serious injury, and for example, if the patient ends up getting a CAT scan while they're in the ED, we will make a decision about follow-up much quicker than that. We may even schedule the surgery from the ED. So the latest it would ever be is the way that algorithm works is 6 days. So it should be quicker than 6, but the latest it would ever be is 6 days, because we'll always see the patient the next Wednesday.
All right. Thank you. We will wrap. We're a little few minutes over time. So thank you for joining our fourth and final session of the 2021 Injury Insight series. A playback of this webinar will be available within 48 to 72 hours. Additionally, we ask that you take the time to complete the webinar survey that will also be sent. Again, thank you, Dr. Cassidy. This was wonderful. I'm sure our attendees really appreciated the information that you've shared. And to everyone else, thank you again for your participation. Bye now.
Bye-bye. Thank you.